everyone, and welcome to another MOGcast entitled MOGAD, Diagnosis and Disease Management, a European Perspective. Today, we are speaking with Professor Friedemann Powell and Dr. Cheryl Hemingway. My name is Julia Leffler, Executive Director and co-founder of the MOG Project, a US-based nonprofit organization devoted to raising awareness, advancing research, and providing support and advocacy for the MOGAD community in hopes of finding a cure. We would like to thank our guests and the MOG squad for their contribution to this MOGcast. Becca?
Hi, thank you. My name is Becca Salke. I'm the Education Consultant, Advocacy Specialist, and Young Adult Support Group Moderator for the MOG Project. I was diagnosed with MOG antibody disease in 2016 after 17 years of being missed or undiagnosed. I had my first attack of ADEM in 1997, followed by over 15 relapses of optic neuritis and an episode of encephalitis, ultimately leading to permanent vision loss and disability. Because of my childhood and young adult experiences, I was inspired to pursue a career in healthcare with the hopes of trying to prevent what happened to me from happening to others. After receiving my bachelor's in psychology, I went to NYU Nursing to pursue a degree and subsequently worked as a registered nurse on a neurology unit in DC. In late 2020, I accepted the incredible opportunity to move to Boston to help Dr. Michael Levy start up the first ever clinical trials in MOG. Rozanolixizumab and satralizumab, both of which are now active and enrolling at MGH. I hope to pursue a PhD and continue my work in research with special interest in psychoneuroimmunology and chronic illness. I'm very grateful and excited to be here today meeting and talking to Dr. Powell and Dr. Hemingway. Thank you. Julie.
Thanks. This MOGcast is being recorded and will be available on our website, Facebook page, and YouTube channel. If you want to submit questions, please feel free to do so by commenting either in the Q&A of this webinar or on our Facebook Live video posted in the MOG Project page newsfeed. We're going to be answering community questions, time permitting. Any other questions are going to be answered, will be answered on a follow-up MOG blog. So this MOGcast would not be possible without the generous support of our sponsors, Roche and UCB. Roche has grown throughout a 125-year history into one of the world's largest biopharma companies, as well as a leading provider of diagnostic tests across various common and rare disease areas. The company owns a long history of neuroscience successes with medicines and diagnostics helping patients across the disease spectrum in areas such as neuroimmunology, neurodegeneration, neuromuscular disease, neurodevelopment, and psychiatry. Roche's ambition is to preserve what makes people who they are and create a tomorrow where neurological disorders are no longer limit human potential. To achieve this, the company collaborates with academia, scientists, patients advocacy groups like the MOG Project, and people like yourselves, industry partners, and clinical trial participants. With their support, there is a collective responsibility for meaningful therapeutic advances for some of the world's most difficult to treat diseases. Roche's commitment in neuroimmunology is to develop safe and convenient medicines that reliably treat disabling diseases of the nervous system. Roche understands the impact of MOGAD on people's activities and their quality of life. Roche's goal is to further support the rare neuroimmunology and MOGAD community and collaborate on development of effective treatments and diagnostic tools to help to tackle this debilitating disease and many others.
UCB is driven to ensure that everyone can live the best life they can as free as possible from the challenges and uncertainty of disease. This ambition fuels their purpose, creating value in the lives of the people they serve now and into the future. Their research and development activities across neurology, immunology, and other areas where their expertise aligns with unmet needs is driven by their connection to the people they serve. Their unique and diverse perspectives serve as guides and inspirations as UCB explores the furthest reaches of science and medical knowledge. They listen to and learn from patients, ensuring that their work has the greatest possible impact by delivering differentiated solutions that create value that cannot be expressed in numbers alone. They seek out tools, technologies, employees, and partners that let them respond to patient needs with purposeful innovations that make a truly meaningful impact. From their headquarters in Belgium to nearly 40 countries around the world, They pursue that ambition each day, promoting a culture of collaboration and curiosity that values diverse perspectives and backgrounds. They are committed to caring for each other, for their communities, for the planet, and for the people who inspire their work.
So thank you, Becca. So I'm really excited to introduce Professor Friedemann Paul. He is director of the Experimental and Clinical Research Center, as well as group leader of the Clinical Neuroimmunology Department of the NeuroCure Clinical Research Center at the Charité Universitätsmedizin Berlin. He finished his medical education in Berlin and has been a board certified neurologist since 2003. Friedemann Paul has been a senior neurologist at the Charité since 2004. Since 2010, he has headed the neuroimmunology outpatients clinic in Buch, a suburb of Berlin. From 2011 to 2016, Powell was professor of neurology at the NeuroCure Clinical Research Center of Charité. In 2016, he joined as a tenured professor of clinical and experimental neuroimmunology at Charité. In 2018, he became a scientific director of the Experimental and Clinical Research Center, and since 2020, vice dean for research with a clinical focus. His research focuses on neuromyelitis optica, neurodegeneration, and neuroprotection of multiple sclerosis, experimental autoimmune encephalomyelitis, neurological complications of chronic inflammatory bowel disease, diagnostic tools of neuroimmunology, such as imaging, OCT, MRI, and ultrasound, laboratory, and CSF biomarkers, as well as the association of structural damage and dysfunction of the visual system in autoimmune disorders of the central nervous system.
And I'm thrilled to introduce Dr. Cheryl Hemingway. Dr. Hemingway has been a consultant pediatric neurologist for over 20 years. She has worked and trained in pediatric neurology at Red Cross Children's Hospital, South Africa, Johns Hopkins, USA, and in the UK, and has been a full-time neurology consultant at a prominent UK hospital since 2006. Her PhD from Imperial College London used RNA technology to explore the host immune response to brain inflammation and infection, and she has used the expertise gained from this to provide specialized clinical care to children with rare neuroinflammatory disorders. She leads the National Inherited White Matter Disorders Service, as well as the Neuroinflammatory Disease Service. This is the largest clinic in the UK for children with MS, MOGAD, and other rare demyelinating and neuroinflammatory disorders. She is also research active with a number of recent important publications and holds an MRC Clinical Academic Research Partnership Award. She's on the steering committee for the International Pediatric MS Study Group and sits on a number of advisory panels for MS trials.
So welcome and thanks everyone for joining us today. We want to talk really about diagnosing MOGAD, and we want to look at this from a European perspective. So the first thing I'd like to ask, and I'd like to ask this to both of you. So what are the typical steps taken when a patient comes into the emergency department with your or your clinic with a demyelinating symptom? Dr. Powell, will you start, please?
Yeah, sure, with pleasure. So indeed, most patients with symptoms suggestive of a demyelinating disease would present to an emergency room because they would experience vision loss, pain upon eye movement, or spinal cord symptoms, or a couple of others. And they would be seen by a neurologist that would, of course, do a neurological examination. We would do a CSF, cerebrospinal fluid analysis, so a spinal tap. We would do a brain MRI, spinal cord MRI, and perhaps other visual tests such as evoked potentials, OCT. In most cases, the patient will be admitted to the ward because not all tests can be done in the emergency room for various reasons. And then usually, and this is kind of common sense and well established in Germany, a long list of differential diagnoses would be worked up. For example, multiple sclerosis, NMOSD, but also MOGAD. And referring back to what Becca has just mentioned, we indeed do see still a high number of patients that have been or are misdiagnosed with multiple sclerosis, but indeed have MOGAD. I'll stop here and let Cheryl chime in.
I think
You're
you're on.
mute.
Yeah. So thank you very much for having me on the program, and for Friedemann for giving some background there as well. So I suppose, one of the differences between pediatric and adult is quite often these children are very ill. And when they do come into the emergency department, I guess the first thing is you get down to basic principles, make sure that child is safe, that they're maintaining their airway, that they're not having any seizures, or they're not excessively sleepy, what we call encephalopathy, that they don't need to be admitted to an intensive care unit and be on breathing support. And I suppose once we've established that no urgent treatment is needed for them, we go back to the basics of taking a history, trying to understand if this is a demyelinating episode. What is the time, the duration? Is it coming on over minutes? Is it coming on over weeks and months? Or is it coming over the more typical presentation, which would be sort of hours to possibly a couple of days in the whatever their features are? Examine them, and then just like Friedemann was saying, if we do pick up a situation where there's a focal neurological deficit, maybe there's visual acuity problems, or they've got weakness, or they've got some ataxia, which is the wobbliness with gait instability, we would organize an urgent MRI scan. Sometimes this isn't always possible in pediatrics because it does need to be done under general anesthetic. I think these children are often under 10. So it is complex in that they often end up with a CT scan first, which doesn't give us the answer. But then when they do go for an MRI, which depends on what the facilities are like at the institution and A&E that they present with, we will often try and do the bloods, the lumbar puncture, and the MRI all at the same time while they are under the same general anesthetic, because it's a lot kinder. And then once we've done that, we sort of look at the information that we've had and make a assessment and decide on what the most likely treatment options would need to be, depending on what we find from those investigations.
You're mute, Becca. We cannot hear you.
Thank you. Thank you both. I just had a brief follow-up question. You mentioned, Dr. Paul, you mentioned the MRI, OCT, the scans you'll do when you diagnose patients. Wondering how that might differ country to country for UK and Germany, and what some of the diagnostic challenges may be.
Okay, so happy to get started. So indeed, we do face challenges getting an urgent MRI at some places, of course, not at academic institutions, but in smaller hospitals, this might be an issue, especially over weekends or holidays. We do not use OCT regularly, with the exception of, again, academic institutions. And we have seen that, and this was an international study that has contributed to this, led by Dr. Chen from the Mayo Clinic, that an OCT in the acute setting may help differentiate MOGAD from multiple sclerosis. This is very relevant because in many places of the world, including sometimes in Germany, it takes a week or two to get the antibodies back from the lab. Yeah. So to have a first assumption of what the diagnostic direction may be, an OCT could be very helpful, but this is not standard of care. And as I just said, one of the other challenges is the antibody testing. Sometimes it takes quite a long time until the results get back to the hospital, and we have to make immediate treatment decisions, but we would never wait for the antibody. So once we are clear on clinical grounds and from the CSF analysis and perhaps an MRI that this is an inflammatory demyelinating CNS condition, we would immediately start high-dose corticosteroids and or plasma exchange. And I'll then turn it over to Cheryl.
Yeah, so I think, again, not dissimilar from what Friedemann is explaining. There are some challenges, and certain institutions and what we call district general hospitals, which are the smaller hospitals around the surrounding areas, may have difficulty, especially for pediatrics, again, accessing a general anesthetic under MRI, because all the equipment has to be non-metal, so it has to be quite specialized, and you can't be with the patient. So it is a slightly higher risk anesthetic for those young children. So they will often need to be transferred into a tertiary center to get these tests done. I guess the most important thing is for an individual to suspect, the clinician who's seeing them, to suspect that this could be an episode of demyelination, and actually to recognize the likely symptoms. And I think this is one of our biggest challenges, is actually to get that recognition that actually this is something which we know is rare, but that early and aggressive treatment can often make a difference to the long-term outcome. So that's the message that really we try and get out. And if we do have a patient that's, a phone call about a patient, we will try and get them in where we can actually do some of these tests together and in a timely fashion. We're very lucky at the hospital I work at in that we have a laboratory virtually on site where we can get a fixed cell-based assay. And if we make the necessary arrangements, we can get a result back in 48 hours, which is really helpful to get an aquaporin 4 or MOGAD result back, which actually often, especially if a case is slightly atypical, it can change your management. And we also have access to expert neuroradiology. And pediatric cases can quite often look typical, but obviously, and I think we can talk a little bit later in the program maybe about some of the more atypical cases, because that's often where the challenge, if a child comes in with a very typical presentation, most of us are comfortable starting to treat with a high dose intravenous steroids and things that we may know make a difference, as Friedemann was highlighting. But, we've had children who presented at 8 months of age. We've had children presenting post-COVID with these inflammatory syndromes. And it's often more difficult to jump in early and aggressively if you don't have the antibody diagnosis. So I think that's, that's really where we need our expert laboratories and radiology colleagues really to help us clinch it.
Thank you for that. I appreciate that. As I 23 years ago, I certainly presented as not very MOG-like, but pretty debilitating as anyway. So, there's this new proposed international criteria, and it's come out just at the end of January. There's a big team, obviously, on that, and we're so excited about it, actually. So I wondered, and this is directed at both of you, and I'll start with Professor Paul. How has that proposed criteria changed the way that you look at patients when you're diagnosing them? Has that really determined anything differently for you?
So it's probably a bit premature to tell, because the paper, as you just said, has been out for less than 3 months, or for just 3 months, from January until end of April now. But what I do see, and also speaking with colleagues about this who have read the paper, is that the publication of the diagnostic criteria has increased the awareness for the condition as being a distinct disease entity from NMOSD and multiple sclerosis. I think this is the key point. The second point that is very relevant in this regard is the fact that we have kind of drawn attention to the issue of antibody titers and assays, because there's lots of confusion with many colleagues in many countries, which assay to use, ELISA versus cell-based assay. We have problems with the ELISA assay in terms of sensitivity and specificity. So the article has made a great point here. And the other point is the high number of probably misdiagnosed MS cases that have low titer MOG antibodies. And again, here, the article made a great contribution. How this will change our approach remains to be seen over the next months and years. But I think having raised the awareness for the condition and the antibody assays was a great step forward.
Yeah, I would completely agree with everything that has been said before me by Friedemann. And it is early days, and I agree, just raising awareness and diagnosing it as a new entity is really an important step for us. I've come up in the sort of neuroinflammatory world where I was told pediatric children don't get MS, or then at one stage when we accepted they do, that every relapsing demyelination was thought to be MS rather than MOGAD. And in the 15, 20 years, we've actually learned a huge amount and made incredible progress, which is really, really exciting. In a preliminary look at what our pediatric data is, we at the moment in our rapid test that we get, which is a fixed cell-based assay, they don't have titers for that. So looking at the diagnostic criteria, we know in pediatrics they are 100% sensitive, and they have a specificity of over 98% in around 50 patients that we've looked at, which is very exciting, actually. So we do know that they have high validity in the pediatric cohort. And I think as time rolls on, it's going to be really important, and particularly in areas where the MOGAD the MOG antibody gets tested when it shouldn't be tested, for patients presenting with abnormal rheumatological signs, and then when there's a low titer, because they very often miss the supporting criteria which are so needed to make the final diagnosis.
Yeah, so I appreciate that. And, I know you both mentioned the titer levels, and, they're very important. But if somebody has a low titer level in an atypical presentation, I guess our question is, would that signal you to do any kind of recommended protocol for that patient so that they don't get lost in the shuffle, revisiting the clinic periodically, and educating the patient as to what steps they should take to react to their worsening symptoms? Or are they just sort of sent away and say, well, you don't really fit the criteria?
Well, I mean, I suppose from my point of view, it would very much depend how they presented. And if they're presented with an episode of demyelination, that patient would always be treated as a high risk for further relapses until we know otherwise. We know that there are antibody negative demyelinating disorders, and that actually there will always be some patients that we can't diagnose, but that we need to treat aggressively and early. So definitely, I wouldn't want to send those patients away. There are another cohort of patients who maybe come in with some visual acuity loss, which can be from a range of different disorders, maybe some genetic underlying causes and things, and they may come up with a MOG or something. But actually, I think one of the really important things is that if you make a diagnosis that's wrong, it stops you finding the correct diagnosis, because people are inclined to look and stop looking. But if you actually keep the sort of in the notes, and I always say when I'm teaching to the medical students and trainees, that actually if you're unsure, keep writing in the notes, unsure of underlying cause, because once you give a little hint of a diagnosis, it gets stuck there and it's incredibly difficult to remove. So yes, absolutely, all patients need to be followed up and constantly reviewed if there are concerns, but definitely I don't think we should give a diagnosis if we're not clear.
I fully agree with Dr. Hemingway. So in case we cannot make a final diagnosis, and we do have these unclear cases or overlap cases, or however you might want to call them, so we tend to follow up these patients every 3 to 6 months. We redo the MRI. We sometimes even redo the spinal tap, although it's a bit onerous and painful for the patient, but we do it. We redo the antibody testing, perhaps the OCT, the VEP, and try, as time goes by, to make a clear and accurate diagnosis. And I also fully agree with regards to the notes. It's better to write down it's not fully established MS, MOGAD, or whatever, rather than say it is MS, and in the end it turns out it's not MS but something else. Because once it's in the notes, it's being copied by subsequent physicians and students and residents without reflection of what has been going on in the past, and that's the problem.
Yeah, absolutely.
Thank you both. I definitely agree with you. Having been undiagnosed, I mean, it was very frustrating growing up and just saying, give me a diagnosis, give me a diagnosis. That's all I wanted. But I think I wouldn't have gotten my diagnosis from NYU had I been given something else before that. So I do understand the importance of leaving it sort of ambiguous there. So thank you for that. I also just wanted to ask about new patients and new diagnosed patients. How do you guys explain this diagnosis to them when there's not that much known, lots being learned about it?
Well, I suppose from a pediatric point of view, I'm quite lucky in that I can talk to the sort of youngest person in the room and explain things quite pragmatically and practically. So often these children are under 10, and I will explain, I normally use a bit of electric flex. You can always find a bit of sort of cabling in the room and explain the concept about myelin. And I then go on to explain a little bit about their immune system becoming misprogrammed. And explain to them basically just a little bit of the underlying pathophysiology of any demyelinating disorder, and try and highlight to them. I've always mentioned that this is nothing they've done. This is not their fault. This is just one of those things which is unfortunate, and nothing could have done anything different, because I think all of us who are parents know we are constantly guilty about what we haven't done or should have done, or, so I need to highlight that this is not something which is preventable. It's just one of those random things. And then I think the most important thing for all of us is to be honest. And it is really difficult, because we have statistics where we can say, X percentage of patients with MOG are likely to go on a relapse, but it doesn't actually mean that much for the individual. And it is difficult to help them recognize that they're living with uncertainty. But we have a team, really. We have an excellent clinical nurse specialist. We have psychology, which is available to help any, especially the young teenagers, where life is challenging and every teenager just wants to be like every other teenager and not actually have to worry about anything that might be sort of slightly meaningful. So I think it is a challenging time to get a diagnosis. And I just really try and make it as reassuring as possible, and highlight that actually there's an awful lot we can do, even if we can't predict the future.
Great, thank you.
So we take a similar approach in adult patients, although we speak to the patient directly usually. We explain what we know, and knowledge, as you know, about MOGAD is still very limited. We explain what we know about the derailment of the immune response in MOGAD. By the way, many patients are relieved that they receive a clear diagnosis if we are able to make this a clear diagnosis, because we get many second or third opinion referrals as a specialized center. So many patients come to us with suspicion of MS or a clear diagnosis of MS that then turns out to be wrong. So they are really very grateful that we can make a clear diagnosis. And then we present the very scant data on prognosis, on relapse risks. And so this is known now that we need follow-up studies on that. And the more difficult question to tackle in such a counseling situation is the question as to whether implement preventative immunotherapy from first attack, or whether we should, so to speak, wait for another attack, which hopefully will never happen. But as we know, we never know what will happen and not. So that's probably one of the most difficult situations in this kind of first provision of advice to our patients with MOGAD.
Thank you for that. So I really appreciate that explanation. So we want to kind of open up the conversation to some of the clinical trials that are going on in Europe for MOGAD. And, those two clinical trials that we know of are satralizumab and rozanolixizumab, or ROXY, as I've been told that it's been being called. And I guess I want to direct this at Professor Paul. What is satralizumab and rozanolixizumab, and how are they created? Are they donor-based like IVIG, or are they created in a different way?
So I'll try to explain very briefly and hopefully in a not too complicated manner what's now going on in the clinical trial landscape for MOGAD. So these two drugs, satralizumab and rozimab, this is another abbreviation I've heard, are being investigated in clinical trials. They're not donor-based, they are bioengineered, which means they are kind of made up in cell models like CHO, Chinese hamster ovary cell lines, that are DNA engineered, and other technological tools that are applied here, but they're not donor-based like IVIG. And there are two different principles as per the mode of action of these drugs. Satralizumab is a humanized monoclonal anti-IL-6 antibody. What is IL-6? Interleukin 6 is a vastly pro-inflammatory cytokine. So a cytokine is a kind of chemical product or a protein that helps with cell-cell communication and has a very important role in the immune response, both to infections as well as in autoimmunity. And we know that IL-6 plays an important role in NMOSD, but also in MOGAD. For example, IL-6 increases the permeability of the blood-brain barrier, which means that then all kinds of stuff, so to speak, from the peripheral circulation, gains access to the central nervous system and can orchestrate and trigger the immune response and the demyelination in the central nervous system. IL-6 is also relevant for the interaction of B cells and T cells, can drive the development of T cells towards a more pro-inflammatory phenotype, Th17, for example, can also stimulate B cells to convert into plasmablasts and plasma cells and produce the pathogenic autoantibodies. And a lot more to say about that, but to keep it short, now looking back at the history in NMOSD, Roche and the scientific community has ample experience and evidence with satralizumab in NMOSD. We know very well the mode of action. We know we have clinical data on attack prevention NMOSD. So there's a very strong rationale to test this in MOGAD because we now know that IL-6 also is one of the key players in MOGAD. Now the other drug is, so to speak, a new kid on the block for neuroinflammation. There is a previous trial, a small trial in myasthenia gravis, another autoimmune condition. UCB is also relatively new to the autoimmune field, but nonetheless, this is also a promising approach. So rozimab targets the so-called neonatal Fc receptor, and this is a receptor that is relevant for the recycling and then finally removal of certain immunoglobulins from the peripheral circulation. And by blocking the neonatal Fc receptor, the idea is that pathogenic autoantibodies such as in MOGAD are kind of degraded, are removed from the circulation. There may be side effects, for example, a decrease of antibody titers that are also relevant for a protective defense against infections and so, but this is something that is currently being investigated in the clinical trials. Both trials have a similar design. For the sake of time, I don't want to go into too much detail here, but happy to take questions if anybody has questions after this conversation. So both trials have a time to attack primary endpoint and are devised as event-driven trials. That means the duration of treatment may vary across patients, and the trial or the RCP phase of the trial before the open label extension starts, so the randomized controlled period, depends on the number of attacks that occur that are predefined by a statistician. There are secondary endpoints. Again, the primary endpoint is time to first attack or time to attack. Secondary endpoints are other clinical endpoints like the number of attacks, disability, imaging findings, etc., etc. And from my perspective, it is very fortunate that we do have two trials running at the moment. I do see the point that sometimes there may be competition of enrollment if certain centers participate in both trials, but from a scientific standpoint and also from the perspective of patients inflicted with this disease, it is very important to have different modes of action, so to speak, being investigated in clinical trials. So I'll stop here and happy to take additional questions.
Thank you so much. That was very informative and helpful. I have a follow-up about rozanolixizumab and the FcRn blocker actions. So we know that rozanolixizumab blocks the FcRn receptor and works to stop antibody recycling. Do you think that targeting the MOG antibody itself, do you think that it'd be possible to do that? And or would that be helpful? Or do you think there are other things at play other than just that MOG antibody?
So very good question. So with a current approach, probably not. It's a more broader approach using rozimab. But in theory, it would be possible to target MOG antibodies or to remove antibodies from the circulation, either by a kind of plasmapheresis approach, where plasma with the antibodies is put in contact with certain columns. This is in theory doable, and I know that people are working on that. Another approach could be a so-called CAR T cell based approach, so where you engineer T cells that would then remove pathologic or pathogenic antibody, MOG antibody producing B cells or plasma cells from the circulation, or would kill these. And there are also groups working on this, albeit in MOGAD, and this might be slightly different from acroporin 4 NMOSD. it's probably not the antibody alone that plays a role. We know from neuropathology studies that also T cells are found in lesions in the brain, CD4 positive T cells. So it might not be the only culprit, we might have to, consider additional therapeutic approaches than for MOGAD, than just targeting the antibody.
All right, great. Thank you so much. And I have a question, this one's for both of you, about the MOG test and about how quickly it is returned in your country. And does it depend on if it's an acute emergency department admission or just an outpatient?
Well, I can follow that up. I think one of the most challenging aspects for us is if we get called about a patient to get the MOG antibody sent from a district general hospital, because very often those laboratories are not used to sending it. I get MAG and other antibodies sent off instead of the MOG. And as public and clinician awareness increases, I think that will get better. As I highlighted earlier, once the patient comes to our hospital, it is a lot easier. At the moment, we have, excuse me, a laboratory that does do the fixed cell-based assay, which is harder to get titers from. It's either sort of high positive or low positive. But if we are convinced that a patient has MOGAD phenotype and the test hasn't returned the result that we expect from the fixed cell-based assay, we can send off a sample that's been taken at the same time to a diagnostic lab in Oxford, which actually we know uses the live cell-based assay, and that works very effectively. It just does take 2 to 3 weeks to come back, which obviously from an acute management point of view is much more challenging, but actually from a definitive diagnosis, it often is very helpful. So we do use the two in comparison. And a lot of the time it's very helpful to know that we've got those two different tests available to in the NHS that we can use.
So here in Berlin, our laboratory at Charité has licensed a commercially available fixed cell-based assay. So once we send our serum to the central lab here at Charité, we get the results back within 2 to 3 days, which is really fortunate. But I know, as I said earlier, that other hospitals in underserved areas, which we do have in Germany, they face issues with this, and sometimes it takes a week or even longer for them to get antibody results back.
And just
often the most challenging thing is to get them into transport, to get them couriered across or something. It's the logistics, because obviously everybody's short of money, and maybe they only have one courier service a week that goes to the main hospitals or something, depending where they are. So you've already got a significant delay just by the logistics of it.
Got it. And are you getting, you have the fixed cell-based assay at your fingertips. Are you getting good intertest reliability? I mean, are they having positives on the fixed cell-based and the live?
So I would say by and large, it's very good. In pediatrics, I think it's slightly easier. I think it's often much more definitive. The patients we test are more definitive, and most of the pediatric patients, when they're tested in a live cell-based assay, come out as a high positive. And that's really by definition, almost they're very explosive when they have their onset with lots of MOG antibodies present, and those MOG antibodies often persist for many months to even years. Again, I think it's Friedemann probably has a slightly different experience in adults who, I think, from my understanding, the titers can wax and wane a little bit more, and they're actually often not quite so robust.
Yes, that's correct. And we often have issues with a seroreversion or seroconversion. So many patients are only positive during an attack. And once they've received corticosteroids or plasma exchangers, so they turn negative. So sometimes it's difficult to make the diagnosis in retrospect. And I know that this is also an issue for the 2 trials enrolling, how to define seropositivity and when to test, etc., etc. We know from multi-center studies that fixed cell-based assays tend to lose between 5 and 15% of probably true positives if they were tested on a live cell-based assay, which means that on clinical grounds, once our fixed cell-based assay is negative and we do have suspicion that this is compatible with MOGAD, we send this to an academic lab that runs a live cell-based assay. And we have a few examples of tests that then came back positive in the live cell-based assay that were negative in our fixed cell-based assay at Charité.
And likewise with, that's, I mean, fortunately being in a national health system, this doesn't actually incur any additional costs for the patient. So we just send it off, and we can, if we think there's going to be a strange situation, we can often send them off simultaneously as well. But normally we go for speed and try and get it back within 48 hours, and we normally don't need to have a clarification.
Thank you both.
Thank you very much. Those are great explanations. I think people really want to know, how that stuff works, and it's very helpful. I want to kind of ask a little bit. We talked a little bit about how rozanolixizumab and satralizumab work. I want to ask a quick question about another medicine, tocilizumab. All seem to be humanized monoclonal antibodies and appear to have some similar makeup. Can you tell us how that tocilizumab is different from satralizumab and rozanolixizumab? What makes them different for a MOG patient? I mean, we already kind of talked about the other two, but tocilizumab in general.
Yeah, so it's the chemical composition. I mean, tocilizumab is also an anti-IL-6 antibody. It's many years older, than satralizumab. It's usually given IV, although there are now a few experiences also with sub-Q. And there is long-standing clinical experience in the field of rheumatoid arthritis, and it has also now been approved for the treatment of temporal arteritis and also for post-COVID, interestingly. So it has a broader range of indications. And we here in Germany conducted a study with tocilizumab and NMOSD and MOGAD, and did find, and this was, before the satralizumab trial in MOGAD started, that tocilizumab has some good effect in both NMOSD and MOGAD, and also in those patients who did not respond to other immunotherapies.
Thank you for that. Becca, you might be on mute.
Go ahead. You can go ahead.
Okay. Well, I want to kind of jump. I know, Professor, I know you said you have to leave a little early. And so we just want to tell you that we think the future is looking bright for MOGAD. And we just want to know that, I'm sorry, we just wanted to ask you, with the acceleration of all this treatment happening, we want to ask what research that you've been working on that's exciting. Maybe you'd want to share with the community.
Yeah, so very briefly, we are doing a couple of research projects in NMOSD and MOGAD. One is about biomarkers. So, for example, the role of GFAP and NFL in the disease course of these conditions, but also from a therapeutic standpoint, we are working on regulatory T cells. So this is another compartment, so to speak, of the immune system that is supposed to play a regulatory role, so to dampen this strong autoaggressive immune response that happens in autoimmunity. So we are taking these cells from patients, we are trying to stimulate them, and then with the idea, this is a long-term perspective, to be able to re-infuse these cells to patients to kind of correct the derailed immune response. And we are also working on an mRNA vaccine-based approach for these two conditions, MOGAD and NMOSD.
Oh, that's exciting. We're really looking forward to seeing what comes out of that. I know you have to go, but I want to thank you so much for joining us today. I know Dr. Hemingway is going to stay. We really appreciate your time, and I'm sure the community appreciates everything you've had to say today. Thank you.
Thank you very much. It was a pleasure to talk to you, and have a good day then.
Okay, you too. Thanks.
Thank you. Bye-bye.
Bye.
Bye.
Okay, so let's see where we were. And Dr. Hemingway, we'd love to go back and talk a little bit more about treatments. I think that, we talked a lot about the clinical trials, and I think that some of these medicines, it's just a general question, because we know that most treatments are currently for MOGAD or immunosuppressive, with the exception of IVIG and subcutaneous. Some of these medicines, and I know theoretically, you know a little bit about how they work. Do you know if satralizumab affects, the immune system and reduces it? And with some of these medicines, do you follow up care, monitoring the immune system during or after treatment with your patients?
Yeah, so thank you. And I think, if we come back to the very beginning explanation, when we explain to a patient that they have an immune-mediated disorder from a misdiagnosed immune system, I will normally talk about the fact that the immune system is there to undertake a number of really important functions. It has an immune surveillance action, which means it will scavenge around your body to try and find any cells that have maybe sort of mutated, which have changed into some sort of abnormal type cell. And this is not that relevant when you're young, because it's not very common, but as you get older, cells do start to change. And we do know with all immunosuppressive treatments, there is a very small but definite risk of malignancies, and that's why we need to keep a close eye on skin cancers and other underlying conditions that could change. So I explain that role of the immune system, and I also explain the role that the immune system is there really to keep us safe and to fight viruses and bacteria and to help us get well when we get some sort of underlying infection. And once a patient understands that, then I think they understand the concept of what happens if we modify the immune system, either with a disease-modifying treatment or immunosuppressive treatment. And most patients recognize that it's a balance of risks, and that if we go in with a very mild modifying treatment, that actually the treatment effects might be smaller, whereas if we go in with a very strong medicine, the risks are going to be higher. I think most people also recognize that you can have targeted treatment, like the B-cell treatments, which we use, which actually take out more like one aspect of your immune system rather than the sort of whole immune system, which we see with, sort of very strong chemotherapeutic agents, which people sort of understand the concept of. So it is important to be aware of the underlying risks that we are exposing a young person to. We try and minimize those risks as much as possible. Before starting somebody on a long-term treatment, we will do a number of bloods to make sure that they don't have any evidence for TB in their system. We might look for underlying hepatitis. We'll look for any infection which we know might flare up if the patient is immunosuppressed, just to make sure we're not missing something that we could treat before starting them on a longer-term course. And we will also, particularly in young people, make sure that they've completed their vaccinations. And this is often something which is quite frustrating, getting records, making sure they've had chickenpox, and that if they haven't had the chickenpox vaccination, trying to get them vaccinated. And it can delay starting, because some of these treatments, that some of the vaccinations you need to have like 4 weeks or 3 months apart, or some of the HPV vaccinations and things like that. So we do try our very best within the balance to sort of modify the risks where we can. The good news is that actually the majority of patients we see tolerate these treatments incredibly well. Young people are generally fit and healthy, and by modifying the immune system just slightly in one domain, it doesn't seem to really impact on them. At the beginning of COVID, we were very anxious. We had just started using quite a lot of one of the B-cell therapies for our MS patients, and we didn't know what it would mean for them when they were 13, 14, 15. But I can say that, whereas we admitted a couple of our patients just because we were anxious, none of them actually needed to be admitted when they got COVID. And we didn't have any patients who were on a sort of immunosuppressive treatment for an inflammatory disease that were particularly unwell from COVID. So that was very reassuring. And while one doesn't want to be blasé, one always wants to take these treatments seriously. I think that generally we've been quite reassured by what we've been seeing in the short term, and definitely with treatments like satralizumab, when we've used it on trials, been used in trials in pediatric patients from 12 and above. We've been very reassured by the safety data that we've seen personally, as well as that which has come out from reporting of the studies. So I do think it's reassuring, but I do worry, when we see a patient who starts a treatment at 10, at the moment, there is no cure for a particular condition like MS. MOGAD, we are unsure exactly what the long-term outcome and how long MOGAD needs to be treated for. But something like MS, those patients we know at the moment there are no cures for. And you're potentially then committing a patient to 20 years or more of a strong immunosuppressive treatment. And we don't know what it means for them in the long term. So it is something which I am anxious about. But again, with a lot of things in medicine, it's a balance of risks. And we know if we leave a patient untreated, that the risks of that are much higher than giving them treatment.
Great.
So long answer, sorry.
No, that's okay. Very informative. Thank you so much. One of our next question, which is to me, a very hot topic, is relapses versus pseudo relapses and how to know what is what. So for example, if someone comes into the emergency room with more than 24 hours of symptoms, but negative MRI, but clearly clinical symptoms, how would you go about saying if it's a relapse or a pseudo relapse?
Yeah, well, I think it's often challenging. One of the good aspects of looking after a patient with a chronic relapsing disorder is that we often get to know our patients quite well. They're a relatively small cohort who we see relatively regularly. They know us and we know them. So we get a reasonably good feeling of what else is going on in that patient's life. We do, of course, have issues where patients come in with symptoms which we are not sure of. I think one of the most important things that we need to, as I said, about seeing a patient for the first time in the ED, you go back to first principles, you go back to history, you go back to examination, and you go back to your special investigations. And if the history sounds very much like a relapse, and if the examination is compatible with the history, then I think I would be most likely convinced that this is a relapse. We know that patients, there are sometimes inconsistent findings on examination. And if there are inconsistent findings, you'd be more likely to go down a pseudo relapse. But actually, if the findings are consistent and actually the reflexes fit with the area of distribution, it can be quite complicated if you've got a sensory change. Actually, there's a very specific pattern of how that sensory change comes if it's coming from a nerve, as opposed to if it's coming from a stress response. So I would go with what my history and examination is, even if the MRI is negative. We know that sometimes the MRI can be a very small lesion that is beyond the resolution of the MRI scanner. You may not have a good technical scan, or actually it may be evolving. And we do see lesions changing over a couple of days to weeks when patients present with MOG, both on the evolving lesions in the early days and over time and on the other end of the spectrum. So the MRI is a tool to help us, but actually I think bottom line is you go back to your history and your clinical examination.
Thank you.
Yeah, thank you very much. That's a great answer. So we kind of want to look at, just what some of the current medicines that you use most for treatments in an active attack and also your preventive treatment. How does that work, and what do you find available and useful in your country for your patients?
Yeah, so I think they're two different approaches really. When we see a young person who we feel has a history, examination, special investigations that are compatible with a MOGAD disorder, what we will normally do is want to give them treatment to treat the acute inflammation None of this is evidence-based. None of it is licensed in pediatrics. So I think that's really important for us to recognize that actually different people do things differently, and there aren't good trials, particularly for some of the first-line medicines even. So the standard of care currently for pediatrics is to use intravenous methylprednisolone, and we would give high dose, and we will give that with some medicine to protect the stomach lining to try and prevent some of the complications. We'll do it monitoring the blood pressure, monitoring the patient's sugar, and after having discussed the risks and complications. And generally, actually, we see patients with MOGAD are very responsive to the intravenous steroid treatment. Even within 24 to 48 hours, you can see good resolution. We do think that early treatment is better than missing treatments and waiting. So that's why we will often act without the MOGAD antibody coming back. But, you know, it is obviously important to be sure of the diagnosis. If a patient's very ill, we will escalate treatment to consider something like plasma exchange, where it's almost like a centrifuge to remove the MOG antibodies by spinning the blood and washing it and replacing it with a saline or albumin, depending on what the institution uses. And I think Friedman was talking earlier about specific columns that can actually sort of like almost catch the antibody as the blood is washed. So we will do that because we know it can actually improve the patient outcome. And the other approach we might use is giving intravenous immunoglobulin. That is really a relatively safe treatment. Again, the evidence for this in trials is very, very scanty. It is a medicine that we use frequently in pediatrics for immune-mediated disorders. And the thinking is that it actually sort of almost absorbs the antibodies and removes them from the blood and protects that in that way. So we will use those 3 treatments for the acute attack the most commonly. And it's often a little bit of a challenge. Do we give the IVIG, and how long do we wait before escalating onto the plasma exchange? Because intravenous immunoglobulins, not only is there a worldwide shortage currently, so we do have a duty to use it widely, it is incredibly expensive. So we don't want to give the IVIG and then the next day do plasma exchange and remove all the IVIG. So one just has to think about it, and these sort of decisions are often made best in expert hands.
Right. Thank you. Out of those treatments you just mentioned, which would you be most likely to use, or a combination of those, for a patient who's really dependent on steroids and unable to really get off them after a relapse?
So I think what one then talks about, so that was really for the acute treatment. We don't treat patients in the long term for a single event. We know that the majority of MOGAD patients do not relapse. And as we were discussing, these immunosuppressive treatments are not without risk. So we, in our institution, we wait for a patient to have a second event. If they have a second event, we treat them again in the same way that we treat for an acute attack, but we then think about putting them on something to prevent them having a third attack. And then there comes that discussion as to what would be best for the patient. And currently, again, there's no evidence, and we're using these drugs off license. So I think it is important for everybody who's listening to be aware that they're on trials, but we will generally use a broad spectrum immunosuppressive treatment like mycophenolate mofetil. I think it's got different trade names in different countries, and keep that with a combination. And if that doesn't work, we'll use MMF together with IVIG. Okay. So that's our current sort of approach at the moment to patients who are relapsing. And fortunately, it seems to be relatively effective.
Great.
Yeah, I want to follow up quickly with that before we ask you our last question, because I know we're running out of time. You know, some of us here in the United States, me included, take the subcutaneous form of IG. It's very convenient and much cheaper because you're doing it at home. Is this something that could possibly come to the UK at some point, or do you anticipate that happening? I know there is not available now.
So we do have a subcutaneous immunoglobulin preparation, which we do use. We use it generally for immunoglobulin replacement for patients who've got hypogammaglobulinemia. I do have one patient on subcut immunoglobulin. From my understanding is that we haven't been encouraged to use it, in that the pharmacy teams feel that we wouldn't be able to get concentrations to a high enough level by using it monthly. So we give monthly IVIG, and we give a high dose, as opposed to what would need to be done much more regularly subcutaneously. But I guess all these things, unfortunately, relapsing MOGAD, well, probably fortunately, relapsing MOGAD is incredibly rare, and getting good evidence-based trials is incredibly difficult for these patients. And one of the biggest challenges, I think, for MOGAD is that it's such a heterogeneous disorder. By that, I mean some patients, have a one-off event and never have a second event. Sometimes it can affect the eye, sometimes it can affect the spine, sometimes you can start with an ADEM followed by optic neuritis 10 years later. It is a condition that's incredibly difficult for us to fully understand the natural history. And because of that, when you think about starting a patient on a significant treatment that has either got sort of a significant discomfort or cost implications, or brings them into hospital every week, one really needs to know that that's actually the right decision to make for that person, rather than putting them through a whole lot of things when they might never have another event.
Well, thank you for that. Becca, go ahead. I think you're on mute.
Oh. Thank you so much. Sorry. Last question before we end. We just wanted to learn a little bit more about your research and any exciting things going on in your lab.
So I think the future, I completely agree with you, Julie. The future is looking really bright. For all of neuroinflammatory diseases, I think that it's really positive. There's a significantly increased awareness, I think, of all conditions in neurology and pediatric neurology that have really changed over the last 10 years. The sort of MS, MOGAD, aquaporin 4 has really exploded. We have access to 15 generic disease-modifying treatments, which, when I started in sort of 1997, there was one injectable beta interferon, and suddenly we've got this explosion of treatments, which has made our landscape a lot more complicated, but it's also made it a lot more exciting. And as Friedemann was highlighting, we now, with especially from all the advances with COVID and the mRNA vaccines, we're in CAR T cells. We're in a really different treatment phase, which I think is really exciting. So there are lots of exciting things. From my own research, I'm quite interested in looking at the cognitive aspects and what the long-term effects are when a patient has MOGAD at 7 or 8 or 9. And that's really what I'm spending time with our neuropsychology, trying to understand what the main issues are and how we could put a program into place to try and help things, and if there's any rehabilitation that we can offer that is targeted to their deficits.
Great.
So
well, you and I will have to connect on that. I'm very interested in the neuropsych aspects of this.
All right.
Yep, absolutely. I want to thank you so much for coming in, and you've had so much great information for everyone. This was absolutely fabulous. And actually, I know Dr. Paul is gone right now, but we also thank him for joining us, and we hope to talk to you again. I mean, I think this is this is an ongoing MOGAD situation here. We've got a lot of research and a lot of things to find out in the future. And so we hope to, in a year or so, see how things are progressing. I appreciate your time, and goodbye, everybody. And we will have our MOG blog out and the video up on our YouTube channel soon. So take care.
Well, thank you so much for asking me, and thanks for all the great work you're doing.
Oh, thank you. Thank you.
Bye.
Take care, everybody.